Hello, I am Dr. Ahilasamy from Chennai. I am going to show a case of CRS with nasal polyposis and sinusitis. You can see the CT scan coronal images. All the sinuses are all involved, both sides except the sphenoid sinus. So I will be doing a bilateral complete FESS except opening the sphenoid, which is not needed in this case. Being a functional, this is a right nasal cavity diagnostic endoscopy. The first step is to pack the nasal cavity with a 4% with the roller gauze soaked in 4% lignocaine and adrenaline in the ratio of 1:1. I take 10 ml of adrenaline and 10 ml of 4% lignocaine. Pack it very well into the crevices. This is a 76-year-old male patient, not without much comorbid condition. I am taking under local anesthesia. Pack very well into the crevices repeatedly to get a good decongestion so that you can give a sphenopalatine block. If you don't get a good decongestion, then you go for a greater palatine block. Again, repeatedly pack to get a good decongestion with the pack, as I mentioned, 4% lignocaine and adrenaline in the ratio of 1:1. You see, the polyps are well decongested. It is arising from the uncinate and more polyps. That's a I could see the sphenopalatine area, so I'll be giving the sphenopalatine block in this case. So no need for a greater palatine block. Patient is very comfortable under local anesthesia. He is a 76-year-old male patient. This is a 23 gauge spinal needle bent, and I am giving the sphenopalatine block where the middle terminate curves and joins the lateral wall. You can see the blanching. I am repeating on the other side also. In this case, I will be demonstrating, showing, I will be doing FESS on both sides, but I am demonstrating one, I am showing the video here only on the right side. The same steps will be repeated on the left side also. Already this video will be 20 minutes, so I don't want to show the same thing on the left side. In this video, even though the surgery is done on both the sides. The shaver, I am taking out the polyps to make it and get a anatomy of the normal structures. So first step is to shave the polyps and get a normal anatomy, then do a FESS. Remember, done under local anesthesia, hardly any bleeding. We don't give any hypotensive drugs. That's the beauty of doing under local anesthesia. You can use any shaver, either Zomed, stores, or a Chinese, or a Hawk, whatever it may be. The suction is the most important and the Zomed blade is the most important. Machine is not important. You can use anything. Of course, you have to use a good source stethoscope. Now I am getting the anatomy. That's a bulla. Polyps over the bulla has been shaved. You can appreciate the quality of field under local anesthesia, which you don't get in general anesthesia. This is the left side I am showing. There are also polyps. That also I am shaving it and to get a anatomy before I start a FESS surgery. Do not injure the septum, middle terminate, inferior terminate. Just touch only the polyp. Now we have come back to the right side. Sucking the blood collected in the choana. Don't trickle too much blood into the choana. Either ask the patient to swallow or you suck it. Otherwise, the patient will aspirate. Now I am using the Dr. Ahilas unsnare dissector, which I have designed and innovated. With that, you can do a very good clean unsnare dissection. It's not over sharp, it's not over blunt, but it is very good to dissect the unsnare. It is available with Sandoz Surgicals of Mumbai. This is about to be done. In one stroke, you go into the antrum. You can see the pus collected inside the maxillary antrum. Then don't pull the uncinate. You just resect the uncinate at the superior part and inferior part and take it out. Just sucking the pus out. This video is done on 25th November, my birthday. So there will be a lot of sounds of messages coming and disturbing. Please avoid that. See the C-shaped uncinate completely removed. That's a bulla. That's a maxillary sinus. Edematous mucosa, pus collection, everything. This patient had a chronic cough, nasal block, hyposmia, everything for around 1 year. Now I am taking the bulla out with the Blackesley forceps. See the quality of field, that's why I love the local anesthesia. If you give good premedication, as in this case dexmedetomidine with fentanyl IV, you will get a very good field. Now I am using the shaver again to widen the middle meatal antrostomy. Sorry for the too much disturbance of the messages coming on my birthday. Please ignore it. So we have gotten very good MMA. The posterior edge of the MMA is being taken out to make it a very wide MMA. Now I am doing the ethmoidectomy and ethmoidectomy with the shaver itself or the microdebrider. Then appreciate the lamina papricia on the lateral. Please appreciate the quality of field under local anesthesia without hypertensive anesthesia. Small bony chips has to be taken out. Constantly suck the nasopharynx or ask the patient to swallow. Don't leave behind any bony chips, otherwise granulations will form around it and post-operatively it will be a trouble. And don't strip mucosa, use true cut instruments or a shaver throughout the surgery. Don't pull the mucosa. This is I am taking out the agarnesis cell, the 0-degree telescope itself. Later I will change to a 70-degree telescope. So curved sucker introduced into the frontal recess. Do not destabilize the middle terminate, which is very important. See how I am maintaining the middle terminate close to the septum. It is almost a full house FESS except sphenoid. very well done on both sides under local anesthesia, very comfortably on a 76-year-old male patient. So be always very gentle to the mucosa. Don't leave behind bare bones. You will get post-operative crustings. Sorry, the voice has too much of disturbance because of the constant messages coming into it. Suppose it might that has not much disease. These patients are treated pre-operatively with 1 week of oral prednisolone. So those diseases subsides, minimal diseases. So I have the concept of one cell behind. That means I stop after the disease. If the one cell behind is good, I stop with that. So here the post-ethmoid cells are lately okay. So I will stop with that. I will not do this P not. Already the CT scan is showing this C not is good. This case, the anti-ethmoidal artery is not dehiscent, so I will not be showing it. That's a frontal recess. So one more frontal cell taken with the blackly. Of course I use that's a frontal sinus coming into view. Now I am operating with a 70-degree telescope. Always use 70-degree telescope to work for frontal if you are doing the routine frontal surgery. Otherwise, if you are using with zero, you have to do a PJ overwalls axillary flap technique or Caroline's window of Richard Harvey's technique. Of course, I sometimes do those techniques also when there is a extensive frontal disease like fungal and everything or draft, etc. You can see the frontal sinus is clear. This is supraorbital cell also open. Do not have camera tilt at any time of this surgery. You can see front supraorbital cell. Then the frontal sinus is quite clear. Only edematous mucosa in the frontal recess area, which is something I have debrided with the rad cyst blade. Patient is very comfortable. Even though in this video I haven't shown the anti-ethmoidal block, which I gave it on both the sides. The editing, I edited it out. Suck it out. See the sphenoethmoidal recess area also. We don't pack the nasal cavity after routine nasal surgeries or FESS surgeries. No need at all. Suppose a model cell, which I will take it out. Some bony chips I am taking out with the Blacksley forceps. Now I am using the 2x2 forceps to take out that post-ethmoidal cell rather than pulling with the Blackesley forceps. These patients are done as daycare procedure, done in the morning and discharged in the evening. I again apologize for the messages coming in and disturbing the video editing from my laptop. This is skull base, skull base, skull base. Again using the true cut to make a remove all the ethmoidal cells. Already this video will be around 18 minutes, so I will not be showing here the other side first, which will be done of the same type. Of course, in this case, it was done by my junior consultant. Thank you for watching, and please contact me for any doubts. I am ready to help you any time. That phone numbers are my WhatsApp number and my email ID. When you don't traumatize the middle terminate and everything, hardly get any synechiae or scarring and crusting. Thank you for watching.